Good morning. I'm Christine Lett. I'm an obstetrician-gynecologist from Regina, and it is my honor to present my project to you. The aim of my study was to improve access to IV iron for pregnant women in Regina. Iron deficiency is the most common micronutrient deficiency in the world, and it disproportionately affects women and children. IV iron is the treatment of choice for iron deficiency anemia in the third trimester. There are a host of risks associated with anemia, both for mom and for baby. For mom, anemia is the most common indirect cause of adverse maternal outcomes, both morbidity and mortality. 10 years out, babies born to iron-deficient moms score lower on neurocognitive development scales. Postpartum anemia and postpartum depression have been strongly associated in a number of studies. Anemia in pregnancy is a public health problem. I did a retrospective chart review of 280 patients in my practice, and I was shocked to discover that 87% of my women were iron deficient between 24 and 28 weeks. By postpartum, in that cohort, 44% were anemic. This is a huge problem that I previously hadn't been paying attention to. There aren't very many guidelines about what to do about iron deficiency in pregnancy. In fact, there's only one, and I used that guideline to create this screening algorithm and treatment algorithm for iron deficiency and anemia in pregnancy. And I don't expect you to read it, but I just want to point out that at 3 times, IV iron is the treatment of choice. So I thought, great, we have best practice. IV iron is how we're going to manage iron deficiency in pregnancy. We're just going to set up this clinic, and we're going to have a whole bunch of iron-replete women showing up for delivery at the Regina General Hospital. It wasn't quite that simple. My first challenge was that the usual place IV iron is given in Regina was overburdened for a number of system reasons, and therefore they decided that they would no longer see pregnant women. So my pregnant women were homeless. In November, we asked eHealth for access to hemoglobin data, which is a key component to my data. And in May, eHealth told us that we needed a data sharing agreement. And I appreciate that confidentiality and privacy are important. However, I'm concerned that blocking access to data housed at eHealth will not facilitate ongoing quality improvement initiatives in our province. The goal of quality improvement is better patient care. So I would like to encourage the members of the audience that work with SHA and eHealth to develop a process where data sharing for QI projects would be streamlined and timely. Thank you. I do have, oh, sorry, that would maybe be a good place to end. But let me tell you some successes. I have the biggest database maybe ever. I have over 4,000 patients in my database, and I can't wait to get the hemoglobin data to plunk it in. Dara Lee shared her story, and it's published on the SHA News about how IV iron literally saved her life in her 8th pregnancy. We did try using the mother-baby unit as a place to administer outpatient IV iron, but the challenge was that our capacity was way smaller than our demand, so we considered that a fail and try again. So we're back at the P in the PDSA cycle, and I look forward to continuing to work on this project until all women in Saskatchewan are iron replete. Thanks so much.